Hi, I'm Wendy Chung. I'm a medical geneticist and pediatrician, and I'm representing Simon Searchlight today and going to tell you what we understand about SCN2A based on the data that you've been providing through Simon Searchlight. So let me first start by explaining what is this Simon Searchlight. Believe it or not, we started this a little over 10 years ago, and this was meant to be able to understand rare genetic conditions that were associated with neurodevelopmental issues, some of which included autism. So that doesn't mean everyone with SCN2A has autism. But that is why we started, is because some people do have autism associated with this. As we've done this, we wanted this to be able to be a safe place, a secure place for participants to be able to contribute information that we could share with you, and that's what we're doing today, as well as be able to catalyze research that researchers were doing and to minimize the burden on families. So in other words, there are a lot of folks behind the scenes that are working on SCN2A, all sorts of different people trying to understand how this particular channel functions. That's what this gene is a sodium channel. And trying to understand that so that we can develop better treatments and better supports for individuals like your family members. In doing so, we wanted to minimize the burden to families by being able to gather the information and de-identify it. That is, that no one knows who a particular participant is, and be able to give that information to many researchers who could use that to, as I said, do the research I just spoke about. So with that, participants could be able to donate once, and potentially even hundreds of researchers use the same information and be able to minimize the burden on the families. So as we're doing this, as I said, we've been doing this for about 10 years. We've been learning as we go along and trying to make this better every step of the way, and we appreciate any feedback that you might want to give us about how to do that. One of the changes that we made, it's been a few years now, but that we changed was to make this online. We did that so that we could have more participants from around the world participate, and this is truly a global effort, as it often is for rare genetic conditions. And I'm proud to say that SCN2A is one of our larger groups because it's one of the more frequent conditions associated with epilepsy, neurodevelopmental disorders, as well as behavioral challenges. As we do this, I want to be very clear, we're committed to doing this for a very long time. As I said, we've already been at this for about 10 years, and I anticipate we'll be doing this for decades more to come. In doing so, and I'll show you this a little bit later, we're still learning. In particular, I think we're still learning about what happens as individuals get older, and so we're very much committed to following the same participants over time. And so that cadence is an annual basis, that is to update and see how things are changing over time, whether they be as individuals start going through puberty or adolescence, as they become young adults, and to be able to see if there might be things that are different when you're 30 or 40 than when you're 14 or 4. So as we do this through a series of different questionnaires, and I said these are online. I'll talk about this, but it starts with being able to review your genetic test report. We do that to make sure that people are in the right club. And although it doesn't happen very frequently, I will say that about 5% of the time, the genetic information is there about a particular gene, but it may be that that's not the major genetic contributor to that child or that individual's developmental or neurodevelopmental condition. And so sometimes we have to redirect. In some cases, I've actually even advised families to get additional testing that identified the true cause, because we want people to get the right answer and we want to give them the right information that's relevant to them. We also have something that at least participants have told us is very valuable. That is to speak with an expert in the condition. So we've got a team of genetic counselors. And again, we try and make this available through a variety of languages because we know we have international participants. So we have a group of genetic counselors talented and fluent in many languages, and when we need to, also translators, to collect what we call the medical history information. So that's information about medically what certain conditions have been, if your child has had a previous diagnosis of epilepsy or a motor coordination condition. We try and collect all that information. We also try and use what we call standardized measures. So these are things that many investigators use to be able to, in this case, for with the Vineland Adaptive Behavior Scale to collect developmental information. What your child is able to do over time, what they can do in terms of everyday skills, what they're capable of. And we do this, as I said, as a standardized measure, because when we think about how this might be available for something like a clinical trial or some intervention, it would be good to know how your child has been doing over time so that we can see if a medication might change that, if it might improve how they do over time, or if it would be that children would stay the same or potentially even do worse. By having this information in a standardized way, we hope this will give more confidence for the researchers who use the information, and especially for regulatory agencies like the FDA in the United States or the EMA in Europe to be able to use these data for future clinical trials to decide whether or not, as I said, treatments or medications are making a difference. Within this, we also have, for the conditions, other instruments that are very specific to what the challenges are for that condition. So in particular for SCN2A, one of the things that we focused on is, for good reasons, epilepsy or seizures. And so there's a very specific seizure survey, and I'll be sharing those data today. And then, as I said, also some other standardized instruments. I want to say that families have been incredibly important with their observations in helping us modify these protocols over time. So within this, we definitely want to hear from you. As I said, we've had families who've themselves been quite expert, either as teachers, educators, therapists, even dentists, who have told us about some of their observations. And in fact, we have developed instruments or questionnaires based on that specific feedback to see if their observations in their child have been something that we've seen more generally across SCN2A or across many other conditions that we see in Simon Searchlight. So again, if you have particular insight, if there's something that you're seeing that you think is important, we want to be able to make this information as specific and as meaningful as we can over time. So please do give us your feedback. And as I said, in terms of the column on the right, longitudinal simply means that we continue to collect information over time. That is, that it's not just one and done, but we want to see how things continue to change, and especially if there's something that you see that is making things better, so that we can share that experience. So let me switch gears now and share the data that we've collected specifically about your family's condition. So as we started this, we have a large number of individuals who are registered, 236 individuals who are registered. Some of those are not necessarily the individuals themselves or a parent of someone with SCN2A, but it might be a relative, someone else in the family who's interested and wants to be sort of kept up to date with newsletters or information about webinars. But of those 236, 146 individuals provided their genetic testing lab report. So that was, again, the first piece to see whether or not SCN2A is appropriate in terms of the right diagnosis and moving forward. We have a team of medical geneticists who go through those genetic test reports and adjudicate or try and decide whether or not this is in fact the correct diagnosis. And one of the things that's specific about this condition is that there are several genetic variants that are not that are of uncertain significance. That's the terminology we use. And that's that there is not enough information at this point to know how that particular genetic change affects the function of that sodium channel to be 100% sure that that's the right diagnosis. Now, in the background, there is a whole team, actually an army of people that are what we call electrophysiologists or particular types of scientists who study those channels and who are looking at this very moment to see how those different channels, how those different variants affect the channel function. And so we expect that over time, more and more of those individuals will be certified, that is to have this sodium channel as the cause of their genetic differences that lead to epilepsy or neurodevelopmental disorders. And that's what part of this research is learning and being able to understand this condition better. About 75% of those individuals who we were sure, absolutely sure that SCN2A was the right diagnosis, 75 of those went on to do medical history interviews as well as complete other questionnaires. And I'm going to tell you the data I'll be showing you today, or the information I'm sharing you today, is about those 75 individuals. So with that, I wanted to give you a sense of the complexity. And if there are any researchers following this talk, you can sort of freeze the talk here and be able to hone in on the particular genetic variants that might be of interest to you. So these are the different genetic variants that we were seeing. And I know this is a little bit complicated for the parents who are not geneticists out there, but just to show you, there are different types of changes that we see. One big class of change that we see are called missense variants. Excuse me. I want to try and help you read the gobbledygook that goes with this, but we do have another recorded lecture that's about how to read your genetic test report, and that goes into much more detail than what I'm going to go in right now. Each one of these is a different genetic change in the gene. Excuse me. The number in the middle here for each one of these is the amino acid or the position in that sodium channel protein that it's affected. And the letters that go before this are the usual amino acid, and then the ones afterward are the ones that are different in the case for this individual. You don't have to memorize this, but for each person, they have a different change. In some cases, I've shown in parentheses a number after this, and what this means is that there are two independent families, two independent individuals that have the same exact change. Doesn't mean they're related, it means that this happened in two different families independently. You can even see that in some cases there are three individuals, independent individuals with the same gene. And so you can see that there are many, many different changes that we see within this channel. What a lot of the researchers are doing is to understand how these various different changes can have different effects on how the channel works. And that's very complicated. I'm not going to spend time going into that today. There are other researchers that you have or will hear from that'll go into that in much more detail. There are some other changes that we think and well, let me back up a step. Everyone has two copies of the SCN2A gene. For all the individuals that I'm showing you here, they have one copy of the gene that's normal and one copy of the gene with the genetic change that I'm showing you here. There are a whole group of individuals who have what we call likely gene disrupting changes. And what we mean by that is that the particular genetic variant that they have causes one of the two copies of the gene essentially not to show up for work. So instead of having two copies of the gene working or two copies of that channel working, they are relying on only having one copy of the channel working. We think that for most of these, what it does is to disrupt or destroy one of the two copies of the gene. In some cases, there's a deletion where it actually takes out the entire gene or a large portion of the gene, so we call that an intragenic deletion. There are some cases where it affects splicing or the way the gene gets cut and pasted together. The gene comes in little pieces, so how it gets cut and pasted together correctly. And we think again that this probably destroys the way the gene is working. So with this, and one of the confusing things is that there are probably differences depending on what effect this particular genetic variant has on the gene. If it disrupts or destroys the gene, that probably leads to one set of ways in which the brain works, as opposed to another set of changes depending on how it affects the channel function. And so with this, it's a little bit confusing because in the slides that I'm going to come up with next, we have lumped everyone together because they seem to be very similar in terms of their manifestations, but there can be some subtle differences. And again, if you look on the website, we've got some other lectures that we've pre-recorded in the past from other family meetings that go into some of those details. Okay, so now let me go into the details about when we put everyone together. For these 75 individuals, one of the limitations is the age distribution. So I just wanted to show you that today. Along the bottom row here are categories of ages. So age 0 to 4, ages 5 to 10. This is in years, by the way. And you'll see that almost all of the individuals we have who have reported information to us are between the ages of 0 to 10. And on this axis here are the number of individuals, showing you that we have about 28 individuals birth to 4, about 27 individuals, 5 to 10. And then importantly, we have a few adolescents that I'm showing you here, but very few people who are over the age of 20. So really all told, I think it's a total of 6 people over the age of 20. So why do I bring this out? Many people ask me, for instance, what will my child be like when they're an adult? What will they be like when they're 20, 30, 40, 50? And what I want to say is that I really don't know the answer to that. We have so few people who are adults that it's very hard for me to anticipate what these folks will be like once they do become adults. And so when we see this, we hope that we can get more information over time from people who are adults, because that's a big gap in our knowledge right now. What I'll say is that as we think about this condition, it's really focused, I think about it as from the shoulders above. And so what I mean by that is it's primarily a brain condition. I'll go into a lot more detail now about what I mean by that, but that's really where we see the effects. It's either directly on the brain or how the brain is affecting other parts of the body. So for almost all individuals, we see one of two things, either developmental delay or intellectual disability. So what do I mean by that? So when we think about the age at which individuals walk or talk or meet some of the other milestones as they advance in terms of how they learn and what they're capable of doing, things come slower. They do come, but they come more slowly. We categorize this as developmental delay when children are younger, and when they get older, we call this intellectual disability. But we're really thinking about these as generally similar things, just varying, like I said, based on age. You'll notice that if you start adding up these numbers, they come to more than 100%, and that's because some individuals have more than one of these things. So there are some individuals who have a diagnosis of developmental delay, and in addition to that, have a diagnosis of autism. So all told, about 40% of the individuals have a diagnosis of autism. But in addition to that, some individuals have issues, for instance, with language as they're learning to talk, may in fact be nonverbal or minimally verbal. We also have other individuals who have problems with attention or attention deficit hyperactivity disorder, or ADHD, problems with anxiety, learning disabilities, or obsessive compulsive condition. All of these, again, if you look by frequency, though, the main conditions that we see are related to development, learning to speak, autism, and intellectual disabilities. In addition to that, one of the things that we see that I do still think is related to the brain, but now the brain affects with the eyes. The eyes are really, in many ways, the window into the brain. One of the main other issues is around vision. And the reason I bring this out and put this as an important factor is that for individuals to learn, they need to be able to accurately see, hear, and sense the world around them. And so I'm trying to bring up things that you need to work with your doctors to make sure that people are attending to these, that they know about these conditions, that they're screening your child for these conditions so that if there is something, they can take care of it. Now, when we think about the visual impairment, there are two levels where we can see the impairment. One is what we call cortical blindness. Cortical blindness means the part of the brain, it's right back here, that is having trouble being able to sense or understand the images coming from the eye. So this is directly a brain problem, and we see about 1/3 of individuals have problems with that. The other individuals that I'm mentioning below, or the other conditions, are really at the level of the eye itself. And so they can have problems with strabismus or a lazy eye. This is something that when necessary can be surgically corrected. So that's why I bring it up. They can have problems in terms of being nearsighted or farsighted. Again, I bring this up because glasses are something that can help with that. They can have problems also with astigmatism, another problem directly in the eye, or cataracts. And again, those are something that an eye doctor, especially a pediatric eye doctor who deals with children with special needs, can be very helpful in terms of diagnosing these conditions and appropriately treating your child or your family member. So this is important to stay on top of this, because this is something that can change over time. And just like I sometimes need need to get a new prescription for my glasses. Sometimes your child might need to get a new prescription or be able to have someone monitor a change in vision over time. So this is, again, something quite common that we see in the community. We can also see problems in terms of how the body either moves or the muscle tone. And this is related, though, directly to the brain and its influence on the rest of the body, in particular the muscles. So we can have some people that have low muscle tone. They can be a little bit loose, a little bit floppy. They may seem weaker, but this is essentially a central or a brain problem and how it's affecting the rest of the body. This is why many of your children are receiving physical therapy. It can help in terms of building strength, especially core strength, helping them to sit up straight, helping them to be stronger in movement. And this is something that almost the majority of individuals do have issues with this as well as help with this. There can be, on the opposite end, issues with high muscle tone or hypertonia. We sometimes call low muscle tone hypotonia. And this can be also called spasticity. And again, physical therapists in this case can be helpful, but to loosen things up so that individuals don't get too tight, that they can stay limber and they can still be able to move, and especially with walking. And again, stretching exercises, stretching. Sometimes the therapist will also help you to be able to teach you how to do these stretching exercises, can be quite helpful. Even within that, we see some individuals who may seem to have problems in terms of either knowing where their body is in space or being able to coordinate those movements. So they may seem to be clumsy. They may seem to have more trouble with tripping or falling and can make them accident prone. So those are, we try and be careful about that. Those are also issues in terms of the brain with coordinating movements and being able to, as I said, have smooth movements, fluid movements, and coordinated movements. Now, some individuals have been diagnosed historically with cerebral palsy. We put this here because this is what parents have told us. To me, cerebral palsy means that there was a lack of oxygen at birth. Whether or not this is truly the underlying cause or whether or not it was really the SCN2A, but may not have been known at birth, I think is one thing that we're still teasing apart. But cerebral palsy can be associated with this high muscle tone or spasticity, and so those may go together. We also have, as you can see, some people with slightly smaller heads, some people with slightly larger heads. This has not been too consistent to finding, and some people that may have a tic or a particular repetitive movements that they have, but again, not very frequent that we're seeing these issues. The biggest issue, or one big issue, I should say, is seizures or epilepsy. And again, you can see the majority of individuals with seizures at some point. Not everyone, and I don't know that everyone will get seizures, but very, very frequent. There are many different types of seizures, and again, we've had recordings from neurologists to talk about the types of seizures, everything from ones that start when children are very young, called infantile spasms, to grand mal or jerking seizures, where you can see the body jerking, to petit mal or seizures where you can see what we call sort of absent seizures, or people staring off, but not necessarily moving, or in fact, not moving at all during those seizures. A variety of seizure types. Again, you can see that these numbers add up to more than 100% because some people have more than one seizure type. Even within the same week, someone could have more than one seizure type. With all of these, though, it is incredibly important, because seizures are so common, that anyone with this condition get a baseline EEG or electroencephalogram. I recommend that this be overnight, a 24-hour video EEG while you're in the hospital, being able to have someone capture on videotape what you're moving. At the same time, they have the electrodes hooked up to the child's brain so that we can see what the electrical movements are while someone is on video. That way, if a parent happens to see an eye blink or a twitch, they can click a button and we can timestamp that on G and compare the brain waves at the time of that movement to see whether or not that's a seizure. And that can be helpful then when the family goes home to know what to look for in terms of the seizure pattern for that child. Now, with these different types of seizures, many of them, I'll get to in a second, respond to medication, and I'll show you the list of medications. In addition, there can be some effects of the brain on the intestine. And so we know that there are brain connections through nerves that go to the muscle. There are also brain connections that go from the brain through the nerves to the stomach. And so we can see symptoms of the intestine because those brain waves aren't quite right. In the same way that there's hypotonia and hypertonia of the muscles, we can see the same thing in the intestine. And so that can lead to things that are moving quite slowly through the intestine and can lead to constipation, or things that move quite quickly through the intestine and lead to diarrhea. And again, some people can have both. That is, that there can be alternating constipation or diarrhea. And for some people, they may have problems with reflux or heartburn because the muscles that keep things in the stomach might be weaker, so they come right back up from the stomach and back up. As you feel that kind of, sometimes some of you have even had heartburn, you kind of feel that taste coming back up in your mouth as things might be washing back up through the stomach. Again, there are medications to use for this. I know some of the kiddos can feel quite uncomfortable, but there are medications, stool softeners, things to keep things moving through, dietary adjustments. And I know many of you are dealing with this already, but just to let you know, you're not alone. In addition, there are some individuals that have had such difficulty with feeding, they have trouble with growing, that in fact their families have used gastrointestinal tubes, or tubes that go straight into the stomach to help with the feeding and medications. And this is not uncommon in the community. We can also see, as I said, that some individuals have had trouble growing, and that is actually what led to the gastrointestinal tubes, or the G tubes. That may be associated also with being on the shorter side, and some relatively minor other hormone issues. But I do want to bring up that hypothyroidism has been seen not frequently, but is a treatable condition. And so just to make sure your doctors are aware of that as well. These conditions are not common, so I want to emphasize not common, but we have seen, for instance, occasionally children that may have kidney problems, mostly related to urine going back up, sort of what we call reflux or nephritis or urinary tract infections, all of those within this sort of uncommon issues, or in the males, some undescended testicles. But I think these are probably just about as frequent as we see with other children, or especially other children with neurodevelopmental issues. One issue that we're seeing as the children are getting a little bit older is scoliosis, or curvature of the spine. We often see that with children with hypotonia. And again, when children go through their growth spurt during adolescence, it's something we see more commonly. So I bring this up so that as your children are starting to grow through growth spurts, please have your pediatrician check the spine, check to make sure everything is straight. If necessary, you can see a pediatric orthopedic surgeon to help determine whether it's something that might need braces, or potentially even something that needs surgery in the future. So we asked you about medications that people, that your children have used that were helpful. Again, similar to the frequency of epilepsy, about an equal number of individuals continued to take medicine for the seizures. Some individuals also taking medicines for their intestinal issues. And then some individuals, really these are medications or sedatives, but they're used for the intention of treating seizures. One new type of medication that has only recently become possible to prescribe has been cannabidiol, or cannabis, or medical marijuana. It's not a large number of individuals, but I will point out that some individuals have found this helpful. And so it's not necessarily possible for all prescribers either to prescribe this or to feel comfortable treating it, because it may be new and something that they don't have experience with, but it is something that some individuals have found helpful. So I'm putting this up here, and I know this may look like gobbledygook, but it's showing you the different types of medications that people have used for seizures. Some individuals have used even more than one medication, because one medication alone may not have been able to treat seizures. This is what I had mentioned as the top, the most common medications are over here on the left. Some of these are very common medications that we use in pediatrics for seizures, and in some cases, one medication alone has been able to take care of things. In some cases, though, it has taken more than one medication. And so I put these up here so that if your neurologist would like to see this information, we have this information freely available to all of the participants. When we asked individuals about the most effective medications, again, some of those ones that I had on the last screen that were most commonly used are being used because, in fact, they were effective, they were working. So this is just showing you those most effective medications. We've also had some individuals use non-medicines. That is a ketogenic diet, a specific type of diet where you don't have any sugar in the diet, or other individuals have used a vagus nerve stimulator. In general, though, I would say that most individuals have found the medications to be effective. And one of the things I think we hope is that with understanding the sodium channel better, there may even be opportunities for new medications, medications that might be more specific to the sodium channel. Again, just showing you by frequency the medications that were being reported as most effective. Medications like Keppra, valproic acid, phenytoin, phenobarbital. Often these were the ones that families were reporting to us as the most effective medications for epilepsy. So to wrap things up, what we see mostly with SCN2A is, again, something above the shoulders, most commonly associated with neurodevelopmental issues, intellectual disabilities, problems with speech, problems with hypotonia, problems with vision, problems with seizures, and some gastrointestinal issues. Parents often ask me, is this a progressive disorder? And it's a little bit complicated to answer that. I think that depends a lot on how effectively the seizures can be managed. If the seizures can be managed, I'm not seeing it as a progressive disorder, not something that's degenerative. On the other hand, the seizures are everything within this condition. In some cases, the seizures can be quite severe and medically refractory. That is, that we haven't been able to control them with medication. And I know the community knows all too well that this can, in rare circumstances, but it can even be fatal with those very, very severe forms of epilepsy. And that's why we're so passionate about trying to find better treatments for this condition over time. With this condition, we do certainly have some other less frequent conditions. About 40% of individuals have autism or autistic behaviors, as well as I've said, and this may change as children age, but scoliosis or other movement problems. For any of the researchers who may be watching this, I want to encourage you to go to the website shown here on the upper left. All of the information that I've shared with you today is freely available in a de-identified manner so that none of the families will actually have their names or their information identified, but all of this information is available to you so that you can learn with the community and hopefully be able to contribute to better answers for tomorrow. So I'll end there, but just to thank the families. I hope this information has been useful to you. I do encourage you to give us feedback if there might be something that would be even more useful, because we want to continue to iterate and improve over time. So